Renanda Crossio Kenneth. Good afternoon, everyone, and a very warm welcome to the 2026 Global Health Partnerships Cymru annual lecture hosted by Hub Cymru Africa. My name is Isra Mohammed. I'm the chair of Global Health Partnerships Cymru. Global Health Partnerships Cymru brings together organizations and individuals across Wales who are committed to improving health through international collaboration. We work closely with charities, health institutions, organizations, universities, and diaspora groups, supporting partner links in Wales with connections to low and middle income countries. Our focus is on making partnerships work together, ensuring that they are fair, they are sustainable, and they are built on shared learning. This also includes supporting ethical international recruitment, strengthening the role of diaspora professionals, and ensuring that global health policy is informed by lived experience of communities and partners. I would like to acknowledge Hub Cymru Africa for hosting this lecture and the Welsh Government for their funding and for their continued support. Just a few practical notes before we begin the webinar. The session will run for an hour and we will finish at 3 p.m. UK time. This event will be in a webinar format, which means that only panelists can share their microphones and video, and all other attendees are therefore unable to use their microphones or video. To contribute to the discussion or to make a comment, please use the chat box function accessible by clicking chat in the meeting control toolbar. And separately, if you want to ask a question to one of the panelists, please click Q&A in the meeting controls toolbar. There you will be able to view other questions attendees have asked and upvote once you agree with. Please do feel free to send in questions throughout this event. There will be an opportunity for the panel to address questions following the lecture. So please continue engaging with questions afterward. We really value your feedback. So please complete the feedback survey we have posted in the chat post at the end of this session, and we'll also have a poll that will be posted at the end of the webinar. Hub Cymru Africa operates a safeguarding policy, which is available on Hub Cymru Africa website. Hub Cymru Africa does not tolerate any form of offensive or abusive behavior, including comments posted in online event chat boxes. And Hub Cymru Africa reserves the right to mute or remove participants who present the safeguarding risk to staff or other participants. It's my absolute pleasure to introduce Professor Tony Jewell, who is hosting this year's lecture. Professor Jewell is a former Chief Medical Officer for Wales and has held senior leadership roles across the general practice and public health. He previously chaired the Wales and Africa Health Links Network, which has since evolved into Global Health Partnerships Cymru. Thank you. I will hand over now to Professor Jewell.
Thank you very much, Isra. Hello, Prynhawn Da, everyone. Good afternoon. Yeah, it's my pleasure to introduce the topic today and speaker. As Isra said, I retired as CMO in 2012 and then became chair of what was then called the Wales Africa Health Links Network. And when I stepped down in 2018 and passed the mantle on to Catherine Thomas, she asked whether I would lead the creation of an annual lecture for Wales, and that's what we've done since. And since that time, we've covered lots of different topics. For example, surgery and conflict areas, global inequalities, sustainability, maternal child health and SDGs, war, peace and health in Africa, decolonizing healthcare innovation, and last year, antimicrobial stewardship. So I think we've kind of covered quite a lot of areas of interest for people wanting to advocate for one planet, global health, sustainable development. And so we came to today's topic, which is global health is in crisis. Really because of the world situation given Donald Trump's presidency in the United States, where, the USA has withdrawn from WHO. It's slashed USAID. Apparently, Elon Musk referred to USAID as a criminal organization. And, the US is withdrawing from lots of the international relief efforts that they have been a huge partner to for many years. And this has left the WHO reeling with job cuts and cuts to services across Africa. And that's the context for why we've chosen this afternoon's session. The other thing is that actually it's not just the US, that the uncertainty in the financial markets internationally has actually led to other Western countries reducing their aid budgets. For example, remember that the UK had a statutory responsibility for 0.7% of GDP. The last government reduced that to 0.5%, and the current government is planning to spend 0.3%. So it's not just blame Trump. I mean, Trump is part of the big problem, but it's not just him. It's actually, we've got a problem in terms of global finances. And that's really why we looked around as to who could help us on examining this, because, foreign aid to Africa has never always been, without its problems, including, aid dependency, and health partnerships as a model has tried to work with countries to develop health partnerships in a bilateral, bidirectional way. And there is therefore also an opportunity in this crisis for health partnerships. Anyway, so Dr. Pete Baker, he's Deputy Director of the Global Health Policy Programme and Centre for Global Development, and he's Deputy Director of the International Decision Support Initiative. Pete is a public health specialist doctor and fellow of the Faculty of Public Health, qualified in medicine in Manchester, and did an MSc in Health Policy Planning and Finance at the LSE and the London School of Hygiene and Tropical Medicine. So Pete is an expert in health financing, and his principal interest is in the evidence, methods, criteria, and institutions needed for prioritization of domestic health expenditure and global health aid. He's working on improving the financing of supply chains, health taxes, reform of the global health architecture, and how aid can better support domestic health financing. Pete has advised Africa CDC, World Bank, Foreign Office, MSF, and a range of countries across Africa and Asia. Back in the UK, he's 5 years a member of the UK NICE Technical Appraisal Committee, which advises the NHS on resource allocation decisions. So I think Pete is an expert in this field, and we very much look forward to hearing what he's got to say. And as Ezra pointed out, if you use the Q&A button at the bottom, we'll come back to the questions, and Pete's talk will take about half an hour. So without further ado, welcome, Pete, and thank you very much for agreeing to speak this afternoon.
Thanks so much, Tony, and thanks, Ezra, and thanks to all of you for the invitation to join you today. It's a privilege in, well, maybe three ways. One is that the topic is so important to me and to the work I'm doing, so I'm delighted to have a chance to talk to you. The second is because I have a deep connection, I think, with a lot of work that you all do. I worked over a period of a couple of years for the King Sierra Leone Partnership, which is a related model to what you all do. And I think it's very impressive, the work you do, and I want to try and help connect some of those dots to some of the difficult global health financing debates that are going on at the moment. Probably the big reason why I'm privileged to speak to you is because of the track record of the previous speakers that you invited, and to be amongst them it really is an honor. Let me just share my slides so you can see where I'm going with today's talk. I'm going to jump straight in to the difficult part, which is that I see this really as quite a deep crisis now we're in global health. On the left-hand side, you'll see the current state of play for what's called universal health coverage. And what it says here is 4.6 billion people, over 50% of the world, are not covered by essential package of health services. And this is really basic stuff. This is kind of treating childhood diarrhea, pneumonia. This is about providing antimalarials. This is about mothers getting antenatal care and safe delivery and so on. Without that, people can not expect to have a reasonable life expectancy, to be able to bring up a family without losing children, and so on. And that has not made the progress that I think we all wanted at the beginning, perhaps, of what's called the Sustainable Development era, from 2015 to 2030. And we're basically at 2030 now, and no one's expecting big improvements on these numbers by then. On the right-hand side, we'll see why this is getting even worse. The crisis is being made worse, particularly because of cuts to aid. Now, aid is not the only thing that drives universal health coverage and access to healthcare. In fact, it's only the secondary cause. The real cause of progress is domestic health financing. But unfortunately, domestic health financing is also stagnating in most countries due to broad economic, let's say, difficulty in many countries around the world. Here, I'm thinking about things like rising inflation. I'm thinking about the post-COVID difficulties in range of economies. I'm thinking, of course, about some of the destabilization from the Trump administration, but it's much more structural than that. It's things like rising debts and expensive debt repayments and so on. So there's not enough domestic money for healthcare, and this has been made much worse by cuts to aid, and particularly the US, but as Tony said, also the UK, and in fact, all the major G7 countries now are basically cutting back aid. The third cause of a crisis is perhaps a more positive cause, but it's still a cause. This is the surge in what's called African health sovereignty, or the idea that has always been present, but perhaps is rising more fast now, which is a desire by African leaders and African communities for autonomy and control of their own health systems, rather than deferring to global donors and global agencies. What that does is it puts tension on the global organizations to reform. So essentially what we've got is a global system that's not working, a global system that's beginning to lose financing, and a global system that's lost the confidence both of donors and also the recipients. So for the first maybe 2/3 of the talk, I'm going to talk about some of those challenges. But then what I'm going to talk about is the positive side. I think there is a route to a solution here. And I think it must be underpinned by two principles. The solution must be driven by rigorous prioritization. There's not enough money, and so we have to accept the economists have a point here. We have to spend the money optimally to save the most lives and build the most effective health systems with limited budgets. Secondly, we have to empower. It can no longer be the case that health systems are guided by big institutions in London or Washington or Geneva. They have to be led and delivered by those close to those who need it, by their own governments and their own communities. So let's dig into last year's crisis in a bit more detail. The current estimates are that aid is being cut by about 40%, health aid, that is. You saw that newspaper clipping of the latest Lancet estimates of 23 million lives at risk. I think that's an exaggeration, and I think we need to be careful with some of those numbers because they forget that actually when aid is taken out, governments will respond and will cover some of the gaps. And so it probably won't be the full 20 million that's been estimated, but it certainly will be large, and it will certainly be millions. We know this is not just a theoretical issue. 80% of the World Health Organization officers are reporting disruption, and therefore the World Health Organization has issued guidance on how countries can respond to these cuts. The global cuts are impacting the World Health Organization. maybe they're facing about a 40 to 50% cut in their budgets. Gavi, this is the Vaccine Alliance that's responsible for a large amount of vaccines in the poorest countries, about 20 to 30% cuts, and the Global Fund for AIDS, TB, and malaria facing 10 to 20% cuts. Interestingly, they seem to have, the Global Fund is the only one of these three that has maintained US support. These numbers really do impact on people. You can see a range of these clippings. They used to be in the paper frequently. They're becoming a bit less common now, I guess. But this is people's access to family planning. This is people's access to HIV treatment that they thought they would be on for life, and now the drugs have stopped flowing, or the facilities that were US funded are now shut, or this is basic anti-malarials for someone's child. So the services have paused, or to extent, particularly early on in the year when the US situation was particularly unclear, the services completely stopped. And now some of the other G7 country services and drug supplies and so on are also cutting. And we have to remember that it's very difficult for countries to respond quickly. It's difficult to raise resources for this. It's difficult to raise them quick enough, given how fast these cuts are coming. So we did some analysis quickly at the beginning of the US cuts, because a lot of people were saying, actually, this is good. Aid is leaving. We're delighted. We don't want the aid anyway. Maybe countries will now step up and lead their own health systems, as you heard earlier. And there is a truth to that, but there's also a pace problem and a scale problem. We found 37 countries where the US support was more than 10% of what the government spends on health. Okay. I don't know how much you followed NHS health financing issues, but trying to get the government to give even 3% to the NHS more than what they previously gave at the moment has been almost impossible, right? And now we're talking about in the same year, so not even letting them get to the next financial year, the US is asking countries maybe to increase health expenditure by 10% to replace it. Very unlikely. 26 of these 27 countries are considered to be low income, so the poorest countries in the world, or in debt distress, so that they're not even able to pay their health services because they're paying so much in debt repayments. So those 26 countries we highlighted as being of major concern because it's totally unreasonable and not possible for them to step in to replace what aid previously covered. We're delighted that the economists picked up on this analysis, and that's what they put it into this nice picture on the right, which I think also flags the concentration of the health financing problem in Africa. As Tony said, UK unfortunately is part of the problem. I think many of us were hoping that the UK would step up and replace some of the US's work, but unfortunately it's made it worse. So the cuts for 0.5% of GDP down to 0.3% are now beginning to bite. The previous funding is running out. So there's this idea of bilateral programs, which is a UK working directly with one country, let's say Sierra Leone. And we used to have 19 of those direct partnerships that were all about 5 to 20 million per year. Most of those are now going. We don't know exactly. It's about to be announced by ministers anytime soon. The multilaterals, the global organizations, have been relatively well protected. The WHO has been almost completely protected. Gavi is only facing 18% cuts and Global Fund about 15%. Much smaller cuts than the bilateral direct country partnerships. I would say probably the funding that goes at least to the to what was FEPS, the global partnership process, presumably will come under this bilateral, so is that substantial risk in the future. So this is directly relevant to the amount of work in the future you guys will be able to do as well. Sierra Leone, as I said, I worked for the King Sierra Leone Partnership in the past, so particularly close to my heart. It's a particularly strong candidate for aid. We wrote a piece in December saying, look, this is a country with really very poor health outcomes, particularly around maternal health. Used to be one of the worst maternal health indicators in the world. It's in debt distress. It's going to find it really hard to raise money to replace aid cuts. There are a wide range of extremely cost-effective ways that you can save lives with just a little bit of money. This is a great place for UK to be working, but yet we're pretty certain the UK will cut its £35 million grant down to less than £1 million. So the UK is part of the problem. This crisis of 2025, though, we must not get too focused on the immediacy of it. We must also see the bigger picture and the longer term picture. And I think it revealed some deep structural problems in aid and in global health financing. I think Tony spoke briefly to this. I think six are worth talking through, and I'm going to go one by one. Aid is inherently volatile. One year, a wealthy country government may decide to do X in country Y, and then the next year it may not. And it's completely discretionary. It can pull money whenever it wants. It can move money around whenever it wants. Countries' health systems are not like that. They need to be planned over many years and long term and stable, particularly for things like long-term HIV treatment and long-term non-communicable disease treatment and primary healthcare and all these critical measures. They need stable funding. Aid tends to be fragmented. Every donor has their own favorite way of doing things, their favorite NGOs, their favorite multilateral processes, and so on. And this leads a government in disarray. There's one nice quote now, I forget which country it's from, where a Minister of Health said, "I'm not the Minister of Health, I'm the Minister for Aid Projects. My job is to coordinate aid projects because they're so fragmented." So this is time consuming for governments and it's also inefficient. They overlap and they produce gaps and so on. It unfortunately tends to displace domestic rather than always add to domestic financing. This is completely rational. If you were in government of a country with very limited tax resources and you saw a donor come in and say, "Don't worry, we'll do HIV, we'll do vaccines," then of course you won't spend your own money on it. The problem is aid money is more volatile and sometimes more poorly prioritized than your own domestic money, and so you may not get the same outcomes. This leads on to the next 2 points. The aid tends to undermine national priorities. It prevents national leaders from setting priorities, and it undermines civil society and media and so on from holding them to account for those priorities because the priorities are set in Geneva and London and Washington. Finally, there's no exit strategy, which is important when there's limited resources. You need donors to leave countries when they become wealthy enough and capable enough to do the health service with their own resources. And in most situations, there's not a well thought through process for that. And so donors tend to stay far too long and consume resources where they're not needed, whilst others suffer without the resources they do need. So we must focus away from these problems towards funding health systems. This graph might look a bit complicated, but I'll just talk you through. It's more of a thought experiment than the precise numbers that you see in front of you. On the right-hand side, it shows you how many lives you could save, essentially. It's DALIs officially, but let's say lives saved for $1,000 spent on the 4 best interventions in one disease, this time HIV. On the left is how many lives you could save if you didn't define the disease in advance. You just said, "I'm going to focus my health system on whatever the 4 best things are to do in my country, regardless of what disease it focuses on." And you can see you can save almost twice the number of lives. And this is just to stereotype a very important point that you, as many of you are health system experts, you know this anyway, that health systems work best when they can treat the most important things for any patient and are not divided up into little pieces for particular diseases and for particular donors' priorities. You need broad health systems providing basic services for everyone. But you also must prioritize the basics. You probably didn't see this paper that came out in the last week, but it was looking at case studies from Colombia and the Dominican Republic. And it was talking about high cost medicines. And it said, because these countries are focusing on very high cost medicines that don't save many lives, and because they're not funding some of the basics, this is actually costing 120,000 QALYs, so years of life, 120,000 years of life lost because of focusing on things that are too expensive. This might be more challenging to some of you because I bet some of you have worked with quite expensive treatments and things you probably worked in quite expensive hospitals, and you've probably worked in partnership with hospitals in developing countries that are also top of their game in their country or doing some quite expensive stuff. You need to be very careful what you champion here because if you champion something that's too expensive for a government to pay for, it will draw resources to that and take resources away from some of the very basics. As we've said, in many countries, what is needed is often basic public health and basic primary health care. And drawing resources to high-cost medicines and tertiary hospitals can be extremely problematic for the total health of the population, particularly when there's limited government budgets and aid budgets are falling. We must also shift away from the 1999 institutions or the 90s institutions that we're familiar with. The context is so very different now in 2025. We've made a lot of progress on infectious diseases. Not all of them, of course, but a lot of progress on the big infectious diseases. People are living longer, and even in Africa, which is the last continent to reach this status, 50% of the disease burden will be non-communicable diseases by 2040. And many of these countries are facing what's sometimes called the quadruple burden. It's all the diseases of poverty, but also all the diseases of affluence, and also all the diseases of road traffic accidents and conflict and so on. That requires a much more complicated health service response than can be delivered by infectious disease people. Also, the main global health institutions are dominated by the G7, by the wealthy countries. But they're not as wealthy in the world as they like to think, or as they used to be. So when Gavi and Global Fund and WHO and others were set up, they dominated the global economy. But now they're only at 31%. We need to bring the rest of the world on board. We need China involved. We need the whole of the EU involved. We need Latin America involved. This needs to become much more of a global movement towards better healthcare. We also need to recognize the power of the decolonization momentum. This is a very important movement that, as I said, is about making sure that power for health systems lies close to the people and the population and governments that they serve. This is a nice sentence from the Ghanaian president. Africa must no longer be the patient. It must be the architect and advocate of its own health destiny. We are called to do systems that do more than respond to crisis. But you'll see many, many similar responses to this. So, what might be the precise solutions that I would suggest could be brought in to prioritize and empower? There's been lots of other proposals. I won't go over those. You can look at them in your own time. But the ones we've been suggesting is that firstly, in the short term, to focus the institutions we do have. So we've got the World Health Organization. It does some great stuff, but it often tries to do way too much. For those that have worked in African countries or in any low-income countries, you'll see that WHO is there as a trusted advisor. It's there providing detailed assistance on a wide range of health problems. It's also in Geneva trying to produce guidance, trying to convene, trying to coordinate. It's also pre-qualifying different medicines to say these are safe. It's trying to do an incredible range of things, and yet its budget has been slashed by 50%. And we need a vision for what a smaller and more effective WHO is. I would suggest it needs to focus on that global aspect. There are a lot of people that can do the advice, including many of you, a lot of people that can do the country support. There's very few people, there's no other organizations, in fact, that can do truly global leadership, truly plot a course to a better global health architecture, that can monitor pandemics, that can produce global advice, and so on. That's where the WHO should focus. And Gavi and Global Fund, they need to double down their focus on the poorest countries. Too often they get dragged into wealthier countries and are not able to leave. When a budget gets cut, that's when they have to start sharpening their focus on those who most need it, and also those who can't do it themselves. Funding services in countries where countries can do it themselves, exactly leading to that kind of aid dependency and fragmentation we talked about earlier. In addition, the way they should fund should change. It shouldn't be anymore, we've decided what area you need, here's the budget to do it. It should be more, here's a single envelope of money. This is what we worked out we can afford for your country. You set the priorities, you spend it how you want. That means accepting we don't know how much they're going to spend on TB, HIV, and malaria, and that's okay, because the country should be setting its own priorities on that. And that will move us towards a more flexible, more empowered, and better prioritized short-term world. I think we should also move towards a model called a new compact. I'm using the word compact on purpose because this suggests a kind of deal or an arrangement between donors and recipient countries. That arrangement should start with locally led prioritization processes by the governments, usually. Then governments should make it clear what they can fund with their own resources, and that should cover the top priorities. And aid only then should come in to expand what can be provided. This turns aid on its head, really. If you think about what aid tends to do, it looks around the world for where something exciting or high priority or important is, and it goes and tries to do it. Whereas we're saying, no, don't do that. That's exactly what government funding should do first. And aid should only come in later to expand what can be provided, even though those might be lower priority. Because you need this core package of health services being government funded, stable, and that expands over time, displacing aid in the lower priority areas. That builds a medium-term vision, because I think that will take time, but the long-term vision is twofold. There are other parts, but this is the principal two parts, I think, of the vision that I would support. One is you need a central body for global governance, global leadership, global coordinating, global decision-making. And that at the core, that is the countries coming together in the World Health Assembly and working through the World Health Organization to deliver on it. Then you need a way of distributing money to countries that cannot afford enough of a health system. I think this needs to be in a single pot, essentially. Donors need to put into it, and as many donors, at least from the G20, if not beyond, should start contributing. This should be allocated to countries based on a formula about how, essentially, how poor they are, what their health burden is, and so on. The details of the mechanism is something we're looking at publishing over the next few months. But essentially, governments would set the priorities and implement it. How do we get to something so dramatically different? Unfortunately, there's no process for this reform. The WHO is debating this in Geneva at the moment. Sorry, I shouldn't say that. I should say the World Health Assembly Executive Board is debating this process at the moment. I'm not sure that a truly global process with all UN members is going to unfortunately work. At the moment, the US just has a history now over this last year of undermining any global process like this. Sadly, we're just in this unfortunate moment where we have urgent multilateral reform needed for all countries to work together, but the US doesn't want to. And I think, unfortunately, there are other actors that also don't want to have a global agreement on this. More likely, I think, is almost like an alliance of like-minded. And I think that the EU, I've said in this blog, I wonder if that could be the EU, European Union, the African Union, and the United Kingdom, because together they have essentially half of aid resources. And of course, African Union being the predominant recipient of resources has more than half of, receives more than half of that. This, I think, could be a process which is not perfectly legitimate, it's not perfectly powerful, but it is legitimate enough and powerful enough and nimble enough, perhaps, to make progress and get towards a world that is more empowering and is better prioritized with limited resources. Okay, so that's the end of my presentation. I hope I've made the case that we're in a crisis, that donors are cutting back, that health outcomes are not improving, that recipient countries have also lost confidence and have limited space to respond with their own domestic financing. This comes on top of deep structural weaknesses, the way that aid is provided. But I think there's a way forward. I think there are constructive short and medium and long-term solutions that prioritize and empower those that these services are meant for. And I hope I've managed to convince some of you to join that journey. Thank you.
All right. Thank you very much, Pete. So we haven't got many Q&A, so if people can start to use that, and it's my old friend Biku Ghosh. Hi, Biku. I'll read out your question, and Pete will also be able to read it, so you can prepare a response. So you say, in my current dealings in several African countries trying to address the challenge of of rising breast cancer deaths, which is, I think, an example of NCDs that Pete mentioned. And one of the big changes, many governments are focusing on expanding private healthcare, ignoring the issue of working in rural communities to raise awareness for early diagnosis. How do you suggest addressing these challenges? Yeah, thank you, Bhikkhu. It's a bit a reminder when you were working in rural Australia with Aboriginal communities. That was a similar challenge. So yeah, Pete, what about NCDs and trying to build in prevention?
Yeah. So there's one side which is the NCDs and prevention, which I think for those of us born in the UK and so on, we need to be a bit humble about. It's not necessarily something we've managed to focus our own health system on either. We tend to focus on treatment more than prevention. Um, it's very important. And the only way to do this, I think, is through relatively strong, well-financed governments, right? This is the primary route to prevention, public health measures, laws, regulations, so on, taxing tobacco, alcohol, and sugar, and so on. There are a range of known measures. It's interesting to think what is the role of partnership schemes or people involved in the aid sector like myself in that, and also UK money. I think there is a role. I think the UK can champion it. I think the UK can regulate its own industry to stop pushing some of the sort of commercial determinants and products that cause some of the NCDs. And I think we can support countries to use aid money for prevention and public health and primary healthcare. Whether the private sector has a big role, it probably does, right? Because they may be the only actors at play. It's difficult to have a coordinated response to improving it. It's not something I'm particularly well placed to focus on. I would suggest our efforts are more around supporting governments to manage the determinants and manage the public health sector's response to it.
Okay, thank you. Come back, Bhikkhu, if you've got some further questions about that relationship between private and public provision. Julian's asked a good question, really, because Pete's model was proposing, well, one of the slides showed that sub-Saharan Africa, in the way that Wales Africa Health Link's always focused on, is the place that we need to focus on for LICs. But the question, as ever in Africa, is how aligned are African governments' views on this agenda? Because I think there's been lots of reporting that actually, the region, Africa, the WHO Africa, and the African Union, and other players don't always play in the way that they might. So interested to hear Pete's response in terms of the proposal, to have a non-US aligned partnership working. So, Pete, what do you think about your experience of African governments and alignment?
I guess maybe unsurprisingly, there's no one answer to that in so much as there's not a single coherent African view on the reform, right? That this is most inevitable, but also a outcome of, let's say, the shorter and weaker tradition of the African Union representing Africa's interests compared to the European Union, as an example. Like the EU is quite a complicated federal state now, and the US is as well. They are more or less able to keep their member states quiet and speak with a common voice when they need to. The African Union isn't that. It is actually primarily driven by member states, so with the African Union sort of in more behind the scenes. The result is actually quite tangible to this question, where each member state wants to capture as much of the US support that's coming back on stream as it can. It also speaks with different voices. There are wealthy African countries and there are extremely poor African countries, and each will speak differently about global health architecture reform. So we've had some support. Africa CDC has been very supportive of the new compact idea, and we published that together. The Accra Resets Initiative, which is led by Ghana, their leading paper references our work on the new compact side as well. but there's not been serious interest in the idea of an AU-EU agreement, AU-EU-UK agreement, to be honest. That has not been taken forward. Shall I just take Paul's comment, because I see that on there as well, about palliative care?
Yeah.
Yeah. I think this is really important and interesting, Paul, and I'm very aware that even some basic things like opiate availability can be a real problem, and palliative care is a real struggle for many countries. And some of it's regulation and things that can be fixed easily, and some of it is quite expensive. And the things that are expensive then need to enter into the prioritization process. And yeah, I worked on nice committees. We were making horrendous decisions every day about rejecting medicines, which we know would alleviate pain, extend lives, and improve quality of lives. But we also knew that if you add in expensive drugs at the top of the NHS right now, when there's not enough A&E nurses and so on, then you're going to overall make the system worse and cost lives. So when budgets are tight, you have to priority set, and that has to include palliative care and even things that are tragic like that when they're expensive. But I certainly didn't mean to say it's only about saving lives. It also is about quality of life as well. And that also doesn't matter what I think, right? What matters is I hope that a range of government decision makers will include quality of life in their decision making when they set priorities.
Thank you. So Sala Kulomula says, in the current aid crisis, when emergencies never seem to end, is humanitarian aid still humanitarian? So this is kind of a question when we read every day, whether it's Sudan, Somalia, all across Africa. You've mentioned Sierra Leone's desperate situation. So what about humanitarian aid being a little bit more holistic in the way I suppose you've just been describing with palliative care?
Yeah, but also I try to support Medicine Sans Frontières Amsterdam and London offices with a prioritization process, because partly they were finding that the average duration of their missions were like 20 years long. And this is not a humanitarian emergency if they're there for 20 years. But they had a point, which was that, well, the need was still there, so why should they leave? I I think the key distinction should be less about humanitarian versus development in terms of crisis and timing, and it should more be about, is the government capable of delivering for its country, or do we need to, and therefore should we put money through that to build health systems over the long term, or there's no capable and coherent government here because of whatever reason, conflict, uh, natural disaster, or whatever, and therefore should we fund through NGOs and people who can fly in and deliver, which you don't want. You want that. That's not a good health system building route, but it may be necessary in brief moments. So I would think of it like that. Where there's no state capacity, then yes, you're going to have to deliver in a humanitarian model. And where there is emerging state capacity, then you should quickly switch. And I think, unfortunately, because often the budgets you have a humanitarian budget and you have a development budget, sadly, that switch is too slow and too hard, and shouldn't be.
Okay. Biku's come back again with this question about state provision and private provision, which is absolutely right. And you don't need to guess how USA would lean, which direction they'd lean to. And one's seen that in lots of countries. I mean, what is your feeling about getting involved in private sector and investment and their whole model of care, as opposed to, I don't know, universal healthcare with primary care being the essence, whole population primary care, that kind of conflict?
I mean, I'm very clear on what I would want. I'm very clear that I would want what publicly funded, primary healthcare driven, highly prioritized services, right, towards UHC. That's prioritized and empowering. But well, what do we do in when we're faced with a reality? Like, what if a government wants a private system? India keeps coming to mind. Like, do we just ignore the private sector in India if you work in India, or rural parts of Africa? Like, if you were trying to build work in a rural part of Africa and make sure quality of care was better, you can't just ignore the private sector. That's all there is. So in that situation, I feel less capable of giving good recommendations, but I'm aware that a traditional UK-based NHS model is just completely wrong. It's just not gonna because that's not the reality you've got. Like, yeah, work with government over the long term to build a better system, but what do you do in the short term when there's people need access to care and all there is private providers? Then yeah, maybe work with them and train them and regulate them and try and be constructive. And we mustn't forget that also we what actually is the private sector. Like usually the whole supply chain around the health system is almost always private sector. Well, you do have some central medical stores and so on, but you'll often have a substantial private sector and everything around it. So we're dealing mostly with countries with quite complex, what are called pluralistic systems, where you have a government and a big private sector, a big government, well, actually small government and big private sector, and you have to deal with that reality rather than be too ideological about what you want.
Yeah. Yes, I wondered what I think you said in your presentation that China has been following its own kind of line on this, and
Yeah.
obviously, China made a fantastic reduction in poverty in China
Yeah.
over the last sort of 20 years or so, and that wasn't through a private healthcare system. I mean, would they be possible allies in this? I know China's got lots of problems in Africa in terms of what they've been doing, resources, scarce measures, all the rest of it. But just in terms of a healthcare model that they would appreciate, if you remember, barefoot doctors and primary care and rural populations versus urban populations and occupational health and all the rest of it. Any thoughts on that?
I think we're thinking of it's an interesting question, but I think we're thinking of it too much as health people. And I don't think that's how China sees it. I think China sees this more in a foreign policy development lens, and so goes to African governments and says, we would quite like your raw minerals. We'll help you develop them by helping you build your mine. What else would you like? And the government says, actually, we need a loan for this, or we need this bridge built, or whatever. And they don't often say we need hospitals built, and they don't often say we'd really like to learn about your barefoot doctor approach, because you're talking about the president and the minister of finance, and so, you're not talking about the minister of health. It's a second order priority for most, and this is a bigger problem, right? That like if or the other evidence point here is the World Bank will provide loans on whatever, and countries don't often ask for much on health. They do ask a bit, but only about 10%. And so if you're going to truly empower and truly prioritize, we have to go beyond health and say maybe it's okay if countries don't want to prioritize health right now. They want to prioritize development and economic growth. Maybe that's okay. I feel uncomfortable with that, but maybe that's okay.
Yeah. But things like the IMF have traditionally been pushing kind of privatization rather than state provision there, haven't they?
Yeah, so that structural adjustment policy was a pretty bad period in the 1980s from those two organizations. They're a bit better now. They're more willing to back public services for healthcare now.
Right.
But the IMF does require budgets to be balanced, and does require fiscal discipline from countries particularly when they ask for loans, and that will definitely cut health budgets. Yeah.
So there's a question from Julian again about, how far can the UK provide some leadership here? Is there any enthusiasm that you sense from the government, UK government? And even if it did, would it have any credibility given the cuts and the use of the UK aid for, as it were, domestic asylum seekers and so on? So what do you feel?
Yeah. Does Starmer have enthusiasm for anything, or what is this government for? It's not clearly for global health and development, right? It doesn't have much passion, excitement for that. It's changed its ministers around it. It doesn't have a clear direction. It's cut the budget. There isn't going to be big political leadership here. The civil service, however, are still quite capable. They still have, the DFID period had lots of money. They brought in good people, and there's still good people there. They've got some serious ambitions to lead this space and want to use the UK's historic leadership in this area for good. Whether the ministers will follow, maybe, I don't know. They're not saying much on the topic right now. They are going to have a conference in May, I think, where they attempt to express some UK leadership on some of these areas. They also they're funding us to think through some of this work. So if you think that some of what I'm saying is leading by ideas, then they are backing some of the ideas. But I don't see big top level political leadership on any of this.
No. And in your experience, has that move from DFID to be embraced by a Foreign Commonwealth Office been helpful or unhelpful in regards to the work that we do?
I mean, broadly, it's been pretty bad. It just consumed a lot of time and effort, and with not much benefits. There is a theoretical benefit which I think is interesting in that if you think that what really needs to happen is countries to build their own health systems, then it's quite useful to have like the ambassador on board and all the British Foreign Office capabilities on board to talk diplomatically with governments rather than just handing over cash.
Yes.
So there was a nice idea there. I just think it hit into the barriers of the reality that the Foreign Office is not interested in this, and it was over and the budgets were cut, so there wasn't so much interest in it, and
Yeah.
also yeah, I think that's it's probably just I think it's also just taken off a lot of time to get
Yes.
like it's taken a lot of civil servants' time just to merge the institutions even.
Yeah. Yeah. I mean, because obviously lots of the participants in this webinar are interested in health partnerships as a model which
Yeah.
is different to overseas aid. Obviously,
Yes.
health partnerships require a little bit of seed corn money, a little bit of
Yeah.
money, but generally speaking, run by people who volunteer lots of their time. Two-way relationship
Yeah.
always strives to be long-term.
Yeah.
Always remember when I went back to one of our health links in Uganda, the guy in charge suddenly said, "Good God, you've come back." Sort of, you've come back.
Yeah.
Was something that always
Yeah.
struck me. So there's,
Yeah.
qualities of long-term health partnerships, two-way, so people from low-income countries coming to, for example, Wales, and people from Wales going to the country, but also with, IT communications, that makes that a lot better from climate change perspective, that you don't always have to
Yeah.
travel. So actually you can do things like webinars, continued training and so on. And there are lots of good experiments like that. For example, actually in Cambridge, the medical school has a link with a medical school in Kenya, and fifth year medical students, have regular webinars with their fifth year equivalent
Yeah.
in
Yeah.
Kakamega, and the students choose the topics, the case studies, or whatever it might be, and they do it from both sides. And then sometimes some students come and do an elective, vice versa. That kind of model of health partnerships is different to
Yeah.
giving aid money in that sense. And I just didn't know whether and it's been underdeveloped, so health partnerships is not a big player in the totality of global health. But do you think this is an opportunity for people to promote health partnerships as a model to be funded and to be pursued with a bit more energy?
Yeah, it's a powerful model and a very efficient model in its own way, because it can draw on NHS resources and expertise and so on. I would like a model where it's efficient and empowering in the sense of countries choosing the partnership. My worry with the government trying to stimulate health partnerships is that, of course, you can only have UK partnerships. What if a country wants a Australian partnership or whatever? Like the problem still is part of the top-down model of aid. Like the money comes first to UK organizations, and then Africa has to kind of accept those are the partnerships on the table. So if there was an opportunity to develop partnerships that were somehow more where the resources and initiative came more from African institutions, that would be even better in my view. Like how do we make this more empowering rather than it already is? And that's a financing lens. The actual relationships, I'm sure, are empowering and equal and so on. But it's just how do we help turn it on its head slightly?
Yes. Yeah. Yeah, I mean, that's sort of work in progress. I mean, the example I
Yeah.
gave, obviously, the medical school in Kenya and the medical school in Cambridge are participants, but they played into the health partnership being the place that provided them with the networks, the relationships, the confidence in it, and that steps into the local hospital there with a local hospital in,
Yeah.
or hospitals in plural in Cambridge. So it's how those things, might grow out of the trust that is
Yes.
developed through a long-term partnership where people, begin to trust each other, and you begin to build up an alumni group. People who've visited and been engaged in it. So that was all I was thinking.
Yeah.
There's one final, perhaps final, slightly long question. It may not be possible to answer this one. But it's referencing the BBC headline, UN risks imminent financial collapse. And this is United Nations, not WHO, which is UN is
Mm.
also under huge pressure due
Mm.
to member states not honoring their mandatory payments. And the US didn't pay what it should have paid either and is leading that field. Do you see any global donors, foundations, or banks being able to step in and fill the void? And will, with programs such as CCEOP, relying on both country and UN UNICEF funding, can you see these initiatives being at imminent risk?
Um, no, I don't see anyone being able to step in, not least because they're also cutting. Um, so the only people that are not cutting are the foundations on that list, and they're already stretched to their limit. And banks, but banks won't do this kind of stuff. So yeah, the UN is facing some big cuts, and there may be some service interruptions in the meantime, particularly around the UN's humanitarian side. Like the UN does a lot of humanitarian work, and that will probably be affected. I don't know whether the anonymous attendee knows this already, but I understand the US has offered a pot of money to the UN, but just on sort of on its terms, on its own terms, and so that may help the UN restart again on certain things. But it is smaller and it is on the US terms. But yeah, we're going to enter in a world with a smaller UN, basically, which is sad as well.
Yeah. If there are any other questions, please answer now. Otherwise, we'll probably draw this to a close. But just giving you a chance, the question about low-income countries and focusing much more on that. I mean, I haven't worked. I mean, have you worked through what that might mean in terms of funding if you began to get a prioritization where actually the first in the queue were low-income countries, before you looked at other criteria? How much would that release in terms of focusing on the most needy? Have you had a look at that?
Yeah, so we've just done that working out for the Global Fund. And I guess partly because their cuts aren't too big, we essentially said if you didn't fund upper so it's called upper middle income countries, so quite wealthy countries really, South Africa and Brazil and so on, and some high income country projects they even do, that would release about 10%, or just over $1 billion, and that would be enough to keep 100% coverage of the poorest countries. But that's a really easy story. Basically, much more hard is other bigger cuts, and that we haven't done all the numbers for that, but you would have to do substantial cuts to middle income country programs.
Yes. Yeah. But I think that is we've often talked about low middle income countries. And obviously, if you started to, shave off some of the middle income, low middle income, and just focus on low income countries, that might be an initial emergency step, I guess.
Yeah.
Okay. So I would just like to hand you over back to Israel, but just personally, thank you very much, Pete, for that presentation and addressing what is a very thorny issue for us at this point, all of us that work in this field, and grateful to you for your time and expertise. So Isra, do you want to take over now? Thank you.
Thank you. Thank you both. And as we come to the end of today's webinar, I would like to thank our excellent speaker, Dr. Peter, once again for such a thoughtful and timely contribution, and to Dr. Tony for moderating the session, continuing to support us with the annual lecture. Thank you so much. And thank you to all of you for taking the time to join and for your engagement throughout this session. Before we close, I would like to highlight a few upcoming opportunities to stay connected with our global health community. On the 11th of February, we'll be hosting an online event on fundraising for health in challenging times, focusing on practical approaches in the current funding landscape. And I think it flows nicely after today's lecture. On the 11th of March, Hub Cymru Africa will mark the International Women's Day with an in-person evening event at the Temple of Peace in Cardiff. And from the 16th to the 18th of March, Global Health Partnerships will be hosting the 2026 UK Global Health Summit at the Royal College of Physicians in London. We very much hope you will be able to join us at one of these sessions or events. And for more information, please check Hub Cymru Africa and Global Health Partnerships websites. Thank you once again for joining us today, and for your continued engagement and commitment to equitable global health partnerships. Have a good afternoon, everyone. Jill Khambauer.
Thank you, everyone.